All right. Welcome back to the podcast. I am joined today with Dr. Anthony Bateman and Dr. Peter Fonagy. And this is an episode on mentalization-based therapy. We're going to talk about borderline personality disorder. We're going to talk about how they got to the development of one of what I would say is the key psychotherapies for borderline personality disorder that work. We're going to talk about their pivotal paper, maybe about reflective function and how that impacts the outcome therapists have with their clients. Welcome to the podcast. It's a pleasure having you guys. I thought we'd start out maybe just talking a little bit about your story and how you met and how you started working together. Dr. Bateman, I understand you're a psychiatrist and you were working in a unit with borderline personality disorder and some antisocial personality disorder. Is that
Yeah.
correct? And then
Yeah.
Dr. Forney, you were kind of paired up together to run research in this unit. Is that how it started? Or maybe you guys can help me understand.
Yeah, to a large extent, I'd say it did start like that. And we met in the main, I suppose, when we were both training as psychoanalysts. And uh, I was working in the health service in the UK in North London, and Peter was working both in the health service and in the university. And he can say that. And I took over a service for people who turned out that, as I discovered, to have borderline personality disorder. I wanted to engage in research, and Peter's an expert in research, much more so than I was. And so I toddled along and said, Peter, well, how do we do this thing called research? He said, oh, come on, let's pull all this together. And that's how it started. So we, had a whole patient population, and we had a research expertise and then some clinical expertise, and we just pieced all that together.
What do you remember from that, Dr. Forney?
Well, I have a slightly different slant on it because Dr. Bateman, as usual, is exceedingly modest. And he is a person who is committed to helping his patients. And he was confronted with a group of patients that were urgently in need of assistance, but at the same time, he did not have the staff that would be able to offer the assistance that was required. So he was faced with the task of creating a mode of intervention that would make these patients somehow accessible to this competence and skill level of the staff that were available to him. And that's really how MBT started. I came from an attachment background, and he came from an adult psychiatry background, and we pieced the two things together. And I think that's how MBT was created. I don't know, Anthony, whether that's your recollection, or am I looking at history as I usually do through rose-tinted spectacles?
No, I think that's very fair. And it was the recognition around that time of borderline personality disorder and attachment that was coming through in research and so on that allowed us to sort of begin to join that up together in a particular way. And as Peter says, that's where MBT came through. I think we should say that at that beginning, that was the time when this concept and idea in attachment research of mentalizing and mentalization was also beginning to develop and be fleshed out. And that was Peter's work and other people at UCL and elsewhere who were fleshing that out. And we then actually integrated that into an approach towards people with borderline personality disorder.
And Dr. Forney, I was looking at some of your background, trying to understand a little bit about your story. Um, you were raised in Budapest and you were born in 1952, Dr.
That
Forney?
is, yeah, that is absolutely accurate. Not that I necessarily want to remember either of these facts, but accurate. I was born Hungarian, and I guess I've remained one, really one way or another, but I was actually a refugee to this country in 1967, 68, and gradually uh, was quite an unhappy person, not being able to speak English and being stuck in England and not being able to join the educational system, which is fairly closed in this country. So I had therapy, and that's what I guess brought me to as an adolescent, and I think that's what brought me to mental health and psychology and all that.
So I read that you were quite depressed initially. You didn't come with friends or family, so you came here. You were all by yourself.
Yeah.
It sounds like you were an adolescent, and there was some a psychotherapist, a child psychotherapist, Anne Hurry at the Anna Freud Center who saw you. And that
Indeed, indeed. And she, at the time I was kind of failing exams as if there was no tomorrow. I had considerable educational difficulties, amongst others. Was also had suicidal ideation and lots of symptoms that I would now be very worried about as a clinician. And then had a very good therapy with Anne Harry. And as I don't know, as it happened, I got stuck in London. UCL, as a university, admitted me with an educational track record that now nobody would look at, um, um, with very low expectations of my exam results. And I have remained loyal to both these organizations, UCL and Anna Freud, ever since, which I'm actually quite pleased about, because most people do not get the chance in life to actually repay some of their debts, and I had. So that was good. I don't know whether Anthony has a similar story.
Anthony, do you have a similar story?
And not quite as exotic, to say the least. I'm a Northern Englander, was brought up in Northern England, but had my traumas here and there as I went through my rather rumbustious adolescence and oppositional adolescence to some degree, partly related to actually going to a boarding school at that time, which caused me some disturbance, to say the least, although I managed my adaptation and so on. But I tended to deal mostly with my problems, actually, as they were, through peer group affiliation. I was great for little gangs, trying to joining up with mates and things, and really taking no notice of adults and things who I found rather discourteous to me overall. But I was certainly discourteous to them. I am sure, and I'm sure they mostly remember that. But so anyway, I went through that English system and then came out the other end. Okay, and I did. Way beyond my academic abilities, funnily enough, really. I managed to skate through somehow and go to one of our major universities, and uh, and from there that sort of settled me to some degree.
Okay. And you were going to be a vet for a while, and
Oh, I
somewhere along
was,
the line
yes.
you
So you found
shifted.
that out, did you? Yes, yes. I thought they were probably easier to get along with than humans in some way, being a vet. So I was, yes, for a time. And then I gradually became much more interested in humans. I thought they were uh, um, uh, interested me greatly. And so I transferred to medicine. That's absolutely right. After 4 years
Was
of
was there
veterinary.
was there a period like that you started doing your own psychotherapy as well? I guess being a part of the analytics center, you must have at that point.
Yeah, that was somewhat later. So I then wasn't sure what branch of medicine I wanted to be in and so on. And I mucked around for a bit, which was quite common in those days, doing different jobs and moving around. And then I then did a light on psychiatry. And
Mhm.
I did a job in psychiatry and actually was influenced very much by two main people, really. One was somebody called Heinz Wolff, who was quite a well-known psychodynamic psychiatrist at the time, and a very warm character. Also been a refugee, as it happens, in 1937 or something like that, 38, from Germany. But he was very influential and interested me in Freud at the time, and then another one a little bit later, Jeremy Holmes, who was very interested in attachment and attachment theory, and so I was influenced by them, and that led me to psychotherapy and psychiatry and so on. So then I went into my own therapy, and from there, I then became more interested in psychoanalysis as a way of thinking and working, and so trained in that. And it was from there, in a way, I think Peter will agree that um, I was then not working in as a psychoanalyst in a way, but working in a social mental health systems. So in the social system, you've got a population of 500,000 you're providing mental health services to, and a high number of them had borderline personality disorder. That was the service I was in, and therefore adapting some sort of treatment which was easily learnable by mental health staff and actually implementable, and also implementable to large groups of people. We had 1,000 referrals a year. Now it's 2,000 and things like
Mhm.
that. This is not small numbers. We have to be able to manage and treat effectively. And that's where MBT became organized.
Yeah, so it seems like, you know, it's a long path to become a psychoanalyst, right? And when I read your initial paper, it sounded like you were training the nurses to be mentalization-based therapists, basically. Is that correct? Or who is actually giving the mentalization-based therapy?
Yeah, as Peter pointed out, the original studies we did was we developed the program and agreed that, and then trained the local staff that we had to implement that program. And they were mental health nurses mainly. They weren't just nurses, they were maybe occupational therapists, counselor level staff. And they were then trained in borderline personality disorder plus mentalizing and mentalizing interventions. Yes. And it's limited training, additional training. We originally gave 3 days plus supervision and so on. And that was the beginning of the research project. Yes.
Three days training and then supervision.
On top of your current mental health training, but with then supervision and discussion. And that supervision was twofold. It was peer supervision, so that everyone delivering met together, and also with a senior person like myself or one or two other people.
Okay, so this pivotal study, I think we should just jump into the pivotal study just to show people how amazing these outcomes were. It was called 8-year follow-up of patients treated for borderline personality disorder, mentalization-based therapy versus treatment as usual. And so this started with 18 months of partial hospitalization. They were receiving 1 time a week of personal therapy, 3 times per week. They were doing mentalization-based therapy and some art therapy, I think another 2 times a week. So it was 9 hours of therapy per week, which I calculated to be over 18 months, 648 hours. And then they followed them up with an additional 18 months of twice a week mentalization based groups for another 18 months. So that was 144 hours. So a total of 792 hours versus treatment as usual. And treatment as usual, it sounds like some of the patients were going to partial, some of them were kind of going to outpatient psychiatrists. But they weren't in this like very systematic, research study where you were going to follow these people for 18 months and then 18 months.
Hmm.
Anything you want to add on that before we get to the results?
I'd just like to clarify two things really for people. One is that was a very early study, and that's right. And it was a comprehensive program, which was over a period of 18 months. And the people were in a partial hospital program, so it was a mixed program. And we followed them after discharge, and we offered them at the time, because they requested it actually, it was very user-led. They requested follow along sort of support, and we organized that in a group. They actually didn't use it, but nevertheless, that was what they requested, and it was offered. They didn't use it much. And we then followed them up after that for, as you say, it was 8 years after the original randomization. So that's one whole study. We did another study, which is a much more focused study, major study trial, which was of outpatient, group plus individual, an hour and a half group and an hour individual for 18 months. And they were then followed up, and we published that data as well for 5 years follow along, which is these are the longest follow studies with a control group comparator of any treatments really in the borderline personality disorder field. So that's the second series of studies. There have been lots of other independent randomized controlled trials around MBT, but those are the two main ones that we conducted.
Yeah. Yeah. There's a lot of people have done subsequent studies. Um, I want to just pull up this study for people who are watching on YouTube. They can actually see this table. I'm pulling up the actual table from the study here. And one of the things that jumped out to me when I read this study years ago now, um, was the drop in the number of suicide attempts was so amazing. So suicide attempt total number, the mean for the mentalization-based group was 0.05, whereas the treatment as usual is like 0.52. So this is like a huge reduction in the amount of suicide attempt number. Anything you want to say on that specifically, like what that means practically?
Um, well, what it means is, in a sense, is that they managed to stabilize themselves enough overall not to have to self-destruct, and they managed to inhibit their impulsivities and so on across time. But what's really important is the first thing is that those suicidality sort of measures dropped relatively quickly in the MBT group, overall in the partial hospitalization group over 6 to 9 months. And that's really important. And secondly, when they've dropped, they tend to remain low. So in other words, you keep your gains, and you keep your gains over long term.
Yeah, I saw that in figure one. This is a great article to read if anyone wants to read one article on mentalization to kind of get them started. I would recommend this one. I'll cite this in the article we write with this episode. The other thing that jumped out to me about this study, which was so amazing, was the medication reduction. And it's truly remarkable. Like so they measured how many over the follow-up 5 years, how many of those years were they on three or more psychiatric medications? And in your mentalization based group, it was like 0.02. So it wasn't even like that. It wasn't that long, right? Whereas in the treatment as usual, it was 2 years out of the five. The patients were on three or more psychiatric medication. Was this a surprise to you as a psychiatrist? I'm just wondering like what it was like when you were seeing this data or when you were in the midst of it.
As a psychiatrist, it doesn't surprise me because I was never convinced that the medications were that helpful for individuals with borderline personality disorder. And since this publication, though, that's been borne out by other data, on looking at medications for borderline personality functioning and so on. So it doesn't surprise me, but in that sense, because in a way, once the individuals in treatment begin to realize they can manage themselves, they can take some sort of really self-control, if you like, and they're able to mentalize themselves. They're able to hold that together. They maintain a level of self-esteem through their mentalizing. They're able to manage their sort of social stressors in life around them by understanding others' motives better or recognizing them and responding to them in a reciprocal way, all of which mentalizing helps you do, that you don't actually need to be taking something to damp yourself down or reduce anxiety and so on. You're actually in a level of self-management at that point. So it wouldn't surprise me if the treatment's working.
That's great. So, okay, one of the things that I just want to comment on and get your thoughts on was the total amount of hours of treatment. And I've always thought, like, you know, a lot of my listeners are probably forced to discharge patients after like 2 to 3 months, right? In America. So in America, you go into IOP 3 days a week, 3 hours a day. Like after about 30 sessions, like I'm really fighting with like the insurance companies. And inevitably patients have to be hospitalized, and that resets the amount of days they can do partial. So sometimes they go back to inpatient, little med change, back to IOP, back to partial, back to IOP. Copy repeat. It takes long to get people completely stable. I don't know. If do you have any comments on that? Like, because I think this is a really important concept that can give a lot of hope for people with borderline personality disorder as well. Like, hey, if you're doing weekly therapy for 1 year and you don't feel like you've gotten to the place that you want to get to, you may need more treatment. Like this may require a lot of treatment, actually. Any thoughts on that? Dr. Fonagy, can I call on you?
Yeah, I mean, I think you can. The question is, of course, what is it that happens over a longer period of time? And as we have done more research and more work in this area, we understanding better that not everything that improves because of the hours that people have with the clinician. A lot happens outside in their lives that helps them maintain themselves in a better organized, less self-destructive, less crisis-driven, less dependent way, because they use their relationships with others better. So I think what our treatments achieve and what perhaps 30 sessions do not achieve, but longer treatments perhaps achieve better, is a capacity to relate to others in a way that will inherently improve the capacity to relate to others, that it becomes a virtuous cycle rather than a vicious cycle of constant rejection, undermining, disappointment, that makes people avoid relationships that could help them understand relationships better. So what I think mentalization-based treatment achieves, and I think probably most other treatments work in similar ways, is a better understanding of why and how other people relate to you the way they relate to you. And then you understand them better. They understand you better because you behave towards them in ways that they find more easy to understand. And the quality of relationships improving, not just within the therapy, but throughout the person's life, is what that sustains them for those 8 years following treatment in the place where they want to be. So I think these factors hang together. And what we hit upon with Anthony all those years ago, and I really don't want to remember how many years ago that was, Anthony, but I'm sure you do. What we hit upon was really this essential quality of all therapies, probably, of improving an individual's capacity to interact and relate with other people in ways that will benefit them in their relationship with others. So it's kind of setting up a positive feedback loop, getting them out of a vicious cycle of relationships where their actions undermined and probably in very severe ways disrupted the potential of these relationships to benefit them. And, it's, I think, probably one of the most important findings of psychotherapy research is how much therapeutic alliance, as it is called, generally underpins the outcomes of therapy. We believe that what therapeutic alliance is in fact reflecting is a mutual understanding or mentalizing of the analyst or the therapist, of the cognitive behavior therapist, of the patient, and the other way around.
Beautiful. Yeah, I'll jump to this study that I recently found like a week ago, and I was so happy to find this right before this interview. It was looking at therapist effectiveness. So this article is called Therapist Reflective Functioning, Therapist Attachment Style, and Therapist Effectiveness. This was published in 2017 by Colligan et al. And what they found was, so they're measuring like the OQ45 of different therapists that are treating a bunch of patients. So they're measuring a good outcome questionnaire that can judge session to session change. And then they look at the best therapists versus the therapists with less patient improvement. Okay. So, and they're trying to find like, what is that factor that is common in the best therapists compared to the worst therapists? Okay. And they found that 70%, 70.5% to be exact, of the variance in therapist effectiveness could be attributed to reflective functioning. And then I looked up the manual for reflective functioning, and Peter Fonagy was like the main author. So I was like, let's go. So reflective functioning is 70% of like what makes one therapist better than another therapist. Like, so one of my questions was, okay, thinking about your lives, have you improved in reflective functioning? If you were to describe like, okay, so they measured it in the adult attachment interview. They're looking at the responses. They're looking at sort of the depth of the answers in the adult attachment interview. Like, was there a psychological mindedness? Was there a reflectiveness that was in capacity to how they describe their relationship with their mother, their father, their different things in their attachments early on? So first question is, have you guys seen an increase in your own reflective functioning? And then the second question might be like, how is mentalization and reflective function similar or different? And maybe you can answer both at the same time.
But Anthony, why don't you go with the first one? Why don't you go with both, and then
yeah. The first one I can comment on in a way, but you're probably better to ask someone else, which is about, has my reflective function changed, and so on and so on. I sure as hell hope so, of course, over time in various ways and so on. It's very interesting, and Peter will give you more detail, but in a sense, I think that when we started out with MBT, one of the things that was around was a sort of level of acceptance of uncertainty, that we sort of don't know what this is. This is this borderline functioning. What's going on for this person? And this is MBT now, in a sense, that actually you're rather authentic sort of puzzlement about someone else's state of mind, where it's coming from, and actually what's driving it, and what they're trying to put across. What are they trying to make you understand, which you're finding puzzling, and so on. All those sorts of things, I think, were very present for me And this is where I began with assessing young people who had made serious suicide attempts. And I was really puzzled by this. Unlike Peter talked earlier, it never even occurred to me to do something like that. So I thought, God, why would someone want to do that? They're 21, they've got the future ahead of them, they're young, they're good looking, beautiful, handsome, and so on. I couldn't understand any of it. And I think that attitude, actually, I suddenly discovered was incredibly important. It led people to tell you more things because they didn't feel you were trying to judge them or you were trying to sort of make them into something which you thought they were or weren't, but actually they hadn't expressed and things like that. So I think it was very important. I think you go through a phase, though, which I recognized in myself at times, and I think it's very easy to do as a clinician, of sometimes becoming really rather low reflective functioning. Think, I've seen this before. Oh, this borderline stuff. Oh, I've seen hundreds of, you sort of suddenly lose your capacity to recognize everything from its individuality and its where it's coming from. You sort of start categorizing, pushing together. And mentalizing an MBT, as it were, opposes that. It's completely the opposite direction. And so in engaging in MBT in a way, you're just learning all the time. And I think it pushes you towards that. So, and you have to maintain that, I think, across time. And that I think I've managed to do, I have to say. But the best people to ask about that sort of thing are others. I do think others often are able to tell you something that you don't quite like to recognize. And others will tell you how good you are at mentalizing or not, or what your points are where you're not so good at mentalizing. So don't forget, ask others who you can trust in, and they'll probably tell you, and you'll listen. And that's good mentalizing.
That's good. I think for those of you who are just kind of getting an initial sort of idea on what mentalizing based therapy is, there is this humility of not knowing. There is this patience that you want to kind of identify what are the perspective differences going on between you and the patient. There is this legitimizing and accepting different perspectives. There is you're actively curious into the life of the patient, how they see things. So I think it sounds like, Dr. Bateman, you were embodying those things without even having invented what you were embodying, because of your just natural curiosity and wanting to understand. Dr. Fortig is smiling. Go ahead.
No, I think that your recognition of Anthony's underlying personality does you good credit, I would say, because Anthony is someone who has remarkable honesty and transparency and humor, and is obviously very relatable and is kind of ordinary. And I think these aspects do embody a good MBT therapist, but they probably embody a good human being, let alone a good psychotherapist. It's a seeking of synchrony with another human being that I think Anthony is particularly strong on, and that I think I'm commenting on, as he requested, as an outside person on his mentalizing. I do feel that another aspect of that, though, which is also embodied within the MBT manual, is an egalitarian stance. So not assuming that we know better, much more assuming that, if anything, we know a little bit less than our patients, and that we are approaching a clinical situation with openness to learn, with curiosity, but also an openness to discover something that surprises us, that we didn't know before. And I do feel that that shift in power relationship is particularly important with some individuals who present with a diagnosis of borderline personality disorder, because they are so used to having to accept the truth that others bring to them and so rarely recognized as the people who bring the truth.
Yeah. So okay. And circling back to Dr. Forty, do you think your reflective function has improved? And maybe just give us a definition of how what you see reflective function is.
But reflective function is the capacity to understand mental states one's own and others in an attachment context. So it is challenging because any strong emotion undermines yours and my capacity to think in mental state terms. So, we had, when we used that manual for the first time, we asked people about their own childhood and their own parents and why they thought that their parents behaved towards them the way they did and so on. And were they aware of the relationship between their parents and how they were historically and how they were now, having changed, so on. So they had to reflect on attachment relationship. And we had these participants, actually, in the first study we did, were rather well-heeled, middle class, or even quite, because of where we recruited them, quite well-educated and extremely reflective in some contexts. But we had attorneys, lawyers, barristers who were obviously extraordinarily able in reflecting on the mental states of the jury, others, in people in general. As soon as they started talking about their own parents, they collapsed. They couldn't reflect. They didn't understand. And this we were able to, fortunately, demonstrate, predicted powerfully to the quality of relationships they developed with their children, even before those children were born. So we could predict how comfortable their children were going to be with them on the basis of how comfortable they were in talking about their attachment relationships with their own parents. The more comfortable, the more reflective, the better able to elucidate the likely feelings of their parents towards them and their feelings towards their parents in a credible, coherent way, the better the children were. And that was another longitudinal study that predicted until the children were into their late adolescence. So we measured at 18 months, at middle childhood, and into adolescence, and the capacity to reflect on mental states predicted forward to the quality of the relationship all the way through.
And that brings up interesting things, just going back to the variance. So you might expect just from that, wouldn't you, Peter, that the reflective function of the clinician is going to have real impact on outcomes overall. So the capacities of the clinician are going to be incredibly important, you would think, from that. And also, the extent of the sort of generalizability of mentalizing and mentalizing interventional processes towards parents who with young children, or problem in families and so on. So MBT and mentalizing in various forms is now delivered to different groups in order to improve, if you like, their reflective function in relation to the attachment processes that they're involved in, which of course is their children and their adolescents or their and so on.
I think everyone in the audience is thinking, well, I'm mentalizing, maybe some of them are thinking, okay, like what is it different about being in an attachment which would color your ability to see reality, right? So the reflective function, you could have amazing reflective function. Like, let's say you were a therapist towards someone you don't feel like a strong attachment towards. But then once you get in this strong attachment, like, what is it about that that changes the way that we view what's going on?
That's for Peter.
Well,
The
I mean,
integration of mentalizing.
at a very simple level, it's conflicting emotions. So it's the intensity of emotions that you experience in the context of um, a relationship that's important to you, that you depend on, or that you really care about, that actually then generates indifferent capacity to reflect. Why does that happen? It probably happens at the very simple level, just because as soon as the networks in the brain that underpin attachment relationships are activated, your capacity to mentalize other centers in the brain, particularly prefrontal areas, temporal parietal junction, get inhibited. And we know that. We have demonstrated, other people have demonstrated it. So at that simple level, there's probably a relationship that's evolutionary, doesn't make sense, because, when you're thinking about who do you want to, you think about who do you love, who do you want to have relationship with, that you'll have children, trying to assess their social trustworthiness through mentalizing probably wouldn't work well for the gene pool. You'd think too much and you probably wouldn't find the right person. It's much more an intuitive experience. So probably there's a good reason for that being a bit of a negative relationship. But I think also there is, again, a sense in which if you experience a powerful emotion, that in some ways undermines mentalizing, and you are unable to understand or even pay attention to the feeling of others, and others suddenly feel incomprehensible, then you try and control others through manipulation, through shouting at them, through doing things that actually will create a relationship that's frightening, that's undermining, that's frustrating, that's coercive, that's distressing. That will then in turn generate further powerful emotions that will further inhibit mentalizing, that will further limit your ability to understand. So what I'm getting at is that these are powerful circular processes, and particularly in an interpersonal context, when one person's powerful emotions, obviously, and their coercive behavior will actually generate powerful emotions in others.
And that sort of brings us back to MBT as well. And this is part of Peter and my partnership over so many years, is translating this then as well into that clinical therapy situation. So if we now have a clear principle, which is well underpinned with science to a large extent, that the attachment processes inhibit mentalizing, and so mentalizing then is off, and that will create interactional processes which further inhibit mentalizing, and emotional sort of tsunamis, that in fact we have to enshrine in MBT a management of that anxiety, that stimulation, not too much, not too little. So to keep mentalizing functioning whilst attachment is still active, rather than them tipping each other over. So you're, in a way, almost trying to rehearse constantly the sense of keeping the mind functioning to a mentalizing level whilst attachment is active.
The only evidence I have to bring to this that I think should mention, just because you raised before, that Dr. Bateman and I, having worked together a number of decades, I cannot remember a single argument that we have had there certainly have never been any raised voices that I can recall.
Pithy remark, I would say occasionally. Pithy remark,
Yeah.
only from me.
So there's never been a client that's created splitting between you guys at all?
I can't remember one.
No.
Was there any? Okay, well, common with borderline personality disorder is splitting different
Yeah.
parties. So this is impressive.
Yeah. Well, I don't think so. Yes and
Right.
no. I mean, in a way, one of the important things is in many treatments for BPD, particularly a team approach ones, is managing that sort of differences in perspective. And differences in perspective are, in a way, harnessed in MBT. We kind of like differences in perspective because we have to see where they're all coming from.
Hmm.
And then we have to work out in some way, actually, some sort of coherence in responsiveness or, understanding that
Hmm.
has to be done.
Okay, that's good. That's good. Yeah, I think it might be helpful. I know that there are some terms that are unique to mentalization-based therapy. Um, I have found them helpful. It's like when someone with borderline personality disorder gets physiologically aroused, stressed out, usually from some interpersonal attachment stress. Um, they go into some different modes, which take them out of like a healthy mentalizing capacity. One of those is psychic equivalence mode. I know you don't love the word, I don't know if you love the word, but in one of your interviews, you said you didn't love the word, but
And that
can
would
you?
be me. I always say I don't like them, no, because everybody else hates them. So I kind of, oh, yeah, I hate it as well. I go along. But yeah, I mean, people worry about them because they're kind of sound like terrible jargon, and so on. But they do have a sort of underpinning meaning and understanding, certainly.
So you never say to a patient, "You're in psychic equivalence mode right now."
Well, I wouldn't, but some people do. In fairness,
Okay.
we do it in MBT. We do a first part where there is some level of joint work about understanding the framework.
Okay.
And the framework, in a sense, is losing mentalizing, catapults us into these ineffective mentalizing functioning. And when it's not working properly, and then our brain kind of gets rooted into them, and they're different kind of ways of the mind brain working, and one of them is called psychic equivalence. So we just have to recognize it, and beginning to recognize when we might be tipping into it, when we're actually in it, and claw our way out of it is really important in treatment. So yeah, they have to recognize it.
So maybe we should define the term just for people who don't know what that means. Um, can you define psychic equivalence mode? When someone enters into that, what are they doing differently? And
Maybe I can, Anthony, do you mind me having a go?
No, have it, and I'll give some
Yeah.
examples.
Okay, so I mean, basically, it's the easiest way to recognize it is an unnatural certainty and suspension of doubt that you are seeing the world the way it is. Because in psychic equivalence, your reality is defined by self-experience. The equivalence, the term comes from the equivalence between the world out there and what's in your mind. So you know how the world is,
Mhm.
and the world is exactly the way you know it to be. It just is. The internal is equivalent to the external. You could call it inside-out thinking, if you want to, but you recognize it because people insist and they seem certain. And what MBT therapy tries to do is just try and introduce a little bit of doubt where previously there was only certainty. Anthony, over to you.
No, absolutely. A lovely description of it. And getting that doubt in there is just the key in the end. A little bit of uncertainty. Whew, that gives us some flexibility for everybody. Right. And typical examples, that people will recognize would be things like flashback is a moment of psychic equivalence. So I tend to have an image, for example, from the past, which is actually experienced as current reality. So I behave according to it. I run, I get out, I do all sorts of things. But it's a psychic equivalent moment, in essence.
So like a statement from a patient, like, Dr. Bateman, I can tell that you're angry at me
Yes.
because of how you're looking at me right now, and I can tell you're angry at me.
Yeah. That would be indicative of a sort of psychic equivalence. There's nothing checked out there. Is certain their self-experience of representation and thinking of experience that someone's angry with them is what that person is.
Right.
They don't say, for example, which they might if they're mentalizing. So it's a quick indicator in the clinical situation. They don't say, "What makes you look at me like that?" And then I could say, "Oh, in what way am I looking at you? Oh, what was in my mind at the time? Oh, I know." And then I might be able to express in MBT what was in my mind about it, and then say, "What were you making?" "Well, I thought you were angry with me." "Oh, right, okay." So, and so on. So you can follow the conversation through.
Mhm.
So they begin to check it out rather than assume it.
Okay, so like let's role play this. Okay, Dr. Bateman, are you ready?
Oh, okay.
Okay. Dr.
Go on.
Bateman, I think you're acting the way you are because you are trying to persecute me. You're trying to make me feel awful.
Gosh, what a horrible thing for me to be doing. Tell me what actions I've just been doing that brought that into your mind.
Well, um, you you and the group were paying attention to the other members more than me, and I think you knew that I had something specifically to say to you today.
What?
And yeah, and you wanted to not hear me, and you're ignoring me on purpose, and you want to do that because you hate me.
Maybe that's a terrible thing. So you were sitting in the group with me actually in that state and seeing me in that state that whole time. I mean, how did you manage that?
Oh, I felt awful. I felt
Really?
absolutely awful. And I think you knew, and I think you were purposefully ignoring me.
That's a terrible thing for me to do, actually, I must say. But just give me a sort of sense, well, what stopped you mentioning it to me at the time so I could actually begin to find that out?
I think I would have felt shame telling the group that. I think I would have felt embarrassed
Really?
telling them all what I knew.
What would have made you so ashamed of that?
Well, I think it would have reminded the group that I'm not your favorite. Okay, is this let's
Yeah,
pause from
this
the
is
role
fine.
player.
I mean, I'm just trying to take a sort of not knowing stance and trying to work
Yeah,
out,
yeah, it's good.
what's my responsibility in this to some extent, because I may have been behaving in a way that actually created that in your mind, in some way, for all sorts of things. But we need to work that out. So it's not just that you're having a delusion here. There's something occurring, and it's causing a lot of stress for you, and I might be part of that, and so on. So we're going to try to work that out.
So, if I can just comment on that, David. So, Anthony started out by being very supportive to you and
Yeah.
saying, that must have been awful. You're just sitting there, and then he tried to clarify and elaborate it. What were you feeling at the time? What was it that I did? How did that affect you? And then you started talking about shame, and you, without knowing it, you started mentalizing.
Oh, okay.
You started, yeah, I was feeling ashamed, and I didn't want to let the group know that I suddenly didn't feel like Dr.
Hmm.
Bateman's favorite, uh, and you started thinking about yourself in a very different way. It's looking at yourself from the outside. That's
Hmm.
basic mentalizing. Uh, then you could have gone, although you stopped the role play, but Anthony would have got to, but how does it change our relationship? Should I try harder? When you are feeling like that, what can I do to make stop you? I don't want to make you feel like that. And you start relational mentalizing. And
Hmm.
that's when you try and cut across that vicious cycle of having an unproductive relationship that undermines mentalizing.
Hmm.
Uh, and you suddenly get into, yes, I can use this relationship with Anthony in a way that makes me feel better about myself.
Okay. That's good. I like that. That's fun. Was that common at all for something you would hear or yeah, okay.
Yeah.
Um,
That's about, I mean, Anthony's not usually this good, but
oh.
but just for the podcast, he pulled himself together. Sorry.
I'm mentalizing that you're mentalizing him as
Yeah.
performing just
He's trying to
exceptional.
make me feel better about myself, so I will.
Yeah.
That's good. Um, yeah. So okay. I'm curious how you guys would differentiate like more of transference focused therapy and mentalization based therapy because it both seems to be working on the interpersonal, what's going on in the here and now between you and the client. Like how is it different? How is it the same? Is this another hour discussion or do we not have?
Well, I think it's probably a long discussion, and the overlaps are huge, I would argue, overall, probably. And I think the overlaps between MBT and other treatments for borderline personality are actually larger than the differences. So it's not just with TFP, say transference focused psychotherapy, it's with dialectical behavior therapy as well, and so on, with particular. I think there are some differences. They might be related partly to the aims, different a little bit in a way. I mean, obviously, the underlying sort of theory is a bit different for each of them, but I think the aims are a bit different. I think sometimes the therapist's attitude might be a difference in terms of the sort of positioning and in relation to the patient. And I think probably the some of the processing sort of aspects may be different as well.
I just to add one thing, David, to what Anthony said. The big difference would be that in transference-focused therapy, probably there are more theoretical assumptions about what's in the patient's mind than we would make. That there is a model. What we would say is that, well, they do have mental lack of inability to mentalize. That's create problems for you, where you find relationships more difficult, and therefore you would be more likely to be in a state of emotional dysregulation that underpins probably causes poor mentalizing and so on. But we wouldn't necessarily put that with aggression or splitting or any particular mechanism. Wouldn't necessarily be part of the model. So we would not equip our therapists with perhaps as rich a toolkit as transference-focused psychotherapy. The converse of that is that our training is, a few days, and training in transference-focused psychotherapy is longer. So it's because our model is as I hope that we illustrated to you from the beginning. We try to make our model simple in order for it to be something that people could do relatively easily with relatively little training.
Okay, so this is just like a taste, of course, of mentalization-based therapy. But kind of as we wrap it up, what are some of the things that you would want people to know coming out of here? Like mental health professionals, people that have never heard about mentalization-based therapy. And then the second question I'll ask is, what's like a next step that you would recommend people take if they want to learn more about this?
I like people to take home that you've got to take an interest in the mind of the person in front of you, not just in what they do. And very often there's quite a concentration on what someone does rather than what their how their mind's working and functioning and how they can use that and so on. So moving from behaviors to minds and so on, I think is a really important sort of sense here. And also that it's take home a sort of inherently relational processing system that they can carry with them, that's going to give them in good stead outside, wherever they go, sort of thing. I mean, for the kind of next steps, it seems to me reading about it and taking some interest in it at different levels, is one thing to be done, like you have in a way, or your professional work and so on. And then maybe some straightforward sort of training, sort of interest and education around it and so on, and then practice, clinical practice and so on.
Excellent. Dr. Fonagy, any closing reflections, closing thoughts?
Well, just be aware that when you are puzzled about what to say to a patient in psychotherapy, the likely reason for that is that your patient has at that moment stopped mentalizing enough to be able to communicate in a way that you would understand. And rather than beating yourself up or thinking about what your supervisor would say in that situation or whatever, rather than just stop and rewind and think, well, what was it that we were talking about when I stopped understanding? And just ask the question, look, I understood really well when you're talking about your sister and the difficult relationship with her. But then the next thing that you went to talk, I didn't realize it. Can we go back? And that kind of recognition that your lack of understanding is a loss of communication underpinned by a loss of mentalizing in the relationship between you and the patient, to me is a major discovery. I stopped thinking about how terrible it is that I don't know what to say to my patients. And rather than thinking, well, maybe I just, we stopped mentalizing together. So maybe we just go back to the last moment where we did mentalize.
That's good. That's really good. I enjoyed watching you guys together. This is I think a great partnership over decades, right? And I can still feel the love between you guys. I'm mentalizing that at least. Hopefully it's not, I don't think it's just a projection. I think it's accurate. Um, but I think there's been some great advancements for the help of many, many people. And I hope that whoever's listening to this can keep digging into this. There's a lot of resources out there, and hopefully I'll have you guys back on in the future to dig deeper for my audience as well. So we'll leave it there for today.
I'd love to. Thanks for inviting us.
Thanks. Thank you, David.